Greetings from the Bronx, New York. This is Dr. Ronald Wharton. I am an attending cardiologist at Montefiore Medical Center and an assistant professor of medicine at the Albert Einstein College of Medicine. And today I thought I would show you a case that I called either two flows too many or endocarditis with a twist, if you will. So the history is this is a woman in her 30s with an acute febrile illness associated with severe dyspnea. She has a history of intravenous drug use. If you look at the moving image, there's not too much subtlety here. What you can see is normal left ventricular systolic function. The left ventricle may be a little dilated, and there is a vegetation on the aortic valve, which is, I think, obvious to just about anybody who does this for a living. And you might say, well, what's so special about this? You know, we see endocarditis echoes all of the time. On the next slide, you can see that this is in color. There is a large jet of aortic regurgitation. No surprise, the aortic valve has endocarditis. It's supposed to have regurgitation. In the next slide, you can see what this looks like in the apical 5-chamber view. There's a large regurgitant jet, as you saw previously. You can see the vegetation coming in and out of the left ventricular outflow tract. The next slide, you can see a very dense aortic regurgitation signal on continuous wave Doppler with velocities that would be consistent with aortic endocarditis. Nothing that I've shown you so far should be surprising. This is nothing out of the ordinary. A lot of AI with an infected valve. Now, in the next slide, you can also see that the velocities through the left ventricular outflow tract was about 1.5 meters per second, and the velocity through the aortic valve of about 2.8, 2.9 meters per second. All is consistent with increased flow due to a hyperdynamic ventricle in a high catecholamine state because of an acute febrile illness with severe AI. So let's take a look at this next slide here. Here's an apical 4-chamber view, and you can see in here that there's a lot of color in that left atrium. Look at it very, very closely. Now that you're done taking a look at it, here, take a look at the apical 2-chamber view. Here you see the anterior wall on the right and the inferior wall on the left. A lot of color going back and forth here. And what I would ask you is to look at it very closely because there's something a little bizarre. In the next slide, I have an arrow next to it. What is that jet that seems to be present in the left atrium? In the next slide, you can see that it's also present in the left atrium in the apical 4-chamber view, and in the continuous wave Doppler through the mitral valve, there is a jet that is at slightly different velocities than the aortic insufficiency jet that you saw. The velocities here are somewhere between 2 and 3 meters per second peaking. What is that? Are we seeing mitral regurgitation in diastole because of the severe aortic insufficiency? Is there a perforation in the mitral valve leaflet due to endocarditis? Do we have endocarditis on 2 valves? Or is something else going on? Well, let's take another look at a slide that I showed you before. This is, again, an apical 4-chamber view. And if you look very closely, in addition to all of the turbulent flow that's going in and out of the left ventricle due to the endocarditis, you see that there is flow in the left atrium that seems to be present not just in systole or in diastole, but in both, throughout the entire cardiac cycle. Now, a perforated mitral leaflet shouldn't do that. That should just give you systolic signals. You can have diastolic mitral regurgitation due to severe aortic insufficiency, but this signal seems to be present in both systole and diastole. Similarly, if you look at the 2-chamber view, you can see the exact same thing. There is a jet in the left atrium that you can't account for by just aortic endocarditis. There's continuous flow in there. Where is it coming from? I'm now going to show you the three-chamber view. And this is why it's so important that when you're looking at an echocardiogram to pay close attention to all the details, and especially when you see one pathologic finding, don't assume that that's the only pathologic finding. There may be others. This is the apical long axis or apical three-chamber view. It's the same or similar view to the parasternal long axis that you saw at the beginning, just rotated 90 degrees. And pay very close attention to the part of the left atrium just superior to the anterior mitral leaflet. We're now going to put color on that in the next slide and take a look at what's happening. Do you notice that there seems to be a continuous jet coming into the left atrium from, of all places, the aorta? So this patient has not one problem, but two problems. And this is such a rare occurrence, I think, that it was worth showing you. I'm going to show you some transesophageal echo views now. If you look at the next slide, you can see that this is the mid-esophageal view at 128 degrees. The left atrium is now on the top, for those of you who are not used to seeing transesophageal echocardiograms. LV on the bottom, the mitral valve in between the LA and the LV, and the aortic valve is the ugly thing that looks like it's infected because it is. And if you notice very carefully as this is playing, there's a little space in the aortomitral curtain at the base of the anterior mitral leaflet, if you will. In the next slide, I stopped it so I can, if you look at the yellow arrow, you can actually see where that defect is. And what's happened here is that the endocarditis has not only damaged the aortic valve, but it has caused a fistula from the aorta into the left atrium. And that accounts for the continuous flow. If you look at the next slide, you can now see that in addition to the aortic insufficiency jet, and by the way, there is some mild MR, but that's not the patient's problem, there is continuous flow from the aorta into the left atrium. In the next slide, I thought I would give some kudos to the surgeons here at Montefiore Medical Center, because this is what the patient's transesophageal echocardiogram looked like intraoperatively after this was fixed. And we had a superb surgeon not just obviously fix the aortic valve, he had to put a bioprosthesis in, but he also had to put a patch sealing the hole between the aorta and the left atrium. In this slide, you can see here that there is no more aortic insufficiency, and that there's no more jet going from the left atrium to the from the aorta to the left atrium. And the final slide shows you the same thing, but without the shadowing artifact of the new sewing ring in place. You can see nice laminar flow through the aorta with no aortic regurgitation and nice, thin, pristine, clean, healthy aortic valve leaflets. So, take-home message, endocarditis is not always limited to just the valves. In fact, we had another case here at Montefiore not too long ago where we had an aortic endocarditis that was complicated by a new ventricular septal defect. So when you see an abnormality, stop there and say, okay, I see it. Is there anything else crazy? And if there is, look closer. Things like this are sort of rare, which is why I thought it was important to share it with the audience, and I hope you found it as entertaining and as instructive as we did here at Montefiore. This is Dr. Ronald Wharton, again, at theheart.org on Medscape from Bronx, New York. Thanks for tuning in.